Good afternoon, and welcome to our webinar on the lessons of the COVID-19 pandemic for the Biden administration's healthcare agenda. I'm David Blumenthal, president of the Commonwealth Fund. The Commonwealth Fund is, for those of you who don't know us, a nonpartisan health policy foundation based in New York City, but national in scope, that focuses on creating a high-performing health system and assuring that all Americans have access to affordable, high-quality healthcare. We're pleased to have a number of distinguished experts with us today to help us explore this topic. I'll introduce them in a moment, but first, let me give you a little bit of background about how this work that we're presenting to you came about. About a year and a half ago, we began planning for the 10th anniversary of the Affordable Care Act by reviewing the lessons that had been learned from the implementation of the Affordable Care Act for payment and delivery system reform. And that resulted in a health policy report in the New England Journal, the title of which is listed on this slide. After it was published, we thought that we could build on that to help prepare a new administration or a continuation of the old administration for the challenges that it faced in payment and delivery system reform. We began that work well before the pandemic occurred, so that has caused us some additional adaptations, but has focused our work a lot more clearly on the pandemic and its lessons for the healthcare system. Could I have the next slide? These are the members of the task force that we brought together. They were a remarkable group of highly experienced and diverse experts who have experience both in government and the private sector and in academia, and they are bipartisan in their composition. We're deeply indebted to them for the time and effort they put together in developing these pandemic-related and delivery system reform proposals that we're going to be sharing with you today. I have the next slide. One of the major contributions of the delivery system and payment reform task force, I think, was to highlight 6 major imperatives that should guide the thinking of a new administration on how to improve the performance of our healthcare system. These include, going from left to right, increasing health system preparedness for healthcare crises and pandemics in general, increasing health system accountability for the cost, quality, and equity of healthcare services, strengthening a deficient primary care infrastructure in the United States, supporting engagement of patients and communities in the healthcare of the United States, reducing administrative burden within the healthcare system, and seeking and finding a balance between regulatory and competitive approaches to governing healthcare markets. Cutting across all these is an imperative to advance racial equity in healthcare. I have the next slide. We have 3 panelists, 3 terrific panelists joining us today. Karen Dale, a nurse by training, is market president and CEO of AmeriHealth Caritas DC and chief diversity, equity, and inclusion officer for AmeriHealth Caritas family of companies. Julian Harris, a physician by training, is a partner in healthcare services and technology investment at the Deerfield Management Company. He's also a former federal official, associate director of O&B for healthcare policy. And Mark McClellan, a physician and economist, who is the Robert J. Margolis Professor at Duke University and director of the Duke Margolis Center for Health Policy, and also, of course, a former director of CMS and a former commissioner of the Food and Drug Administration. Next slide. A couple of housekeeping issues. All participants in the webinar are muted. Today's webinar will be structured similar to a conversation with time for questions and answers, both among our panelists, and also from the participants in the webinar in the audience. To ask a question, we ask that you please use the chat box feature. Use the raise your hand feature if you cannot hear us or have other technical difficulties. The webinar is being recorded, and the recording and all resources will be shared via email after the conclusion of the session. So let me turn now to the first issue. There are three issues that we'd like to share with you from the work of the Task Force on Delivery System and Payment Reform. The first has to do with preparedness and its implications for the healthcare agenda of the Biden administration. The second has to do with one form of accountability, and that's accountability through payment reform. And third, we'd like to talk with you about the cross-cutting equity perspective and the recommendations of the task force that flow from its interest in equity, cutting across all the six pillars of our recommendations. I'm going to start with Julian. Welcome, Julian. Thank you for joining us. And I'm going to be talking with him about preparedness. And my question for him is, first of all, how do you think, Julian, that the federal government can get to what the task force describes as a culture of national preparedness and create a healthcare system, delivery system, talking about the delivery system here, that can effectively respond to the pandemic now and to our next national emergency?
Thanks, David, and it's a pleasure to have a chance to join you all today. I think that we have a real opportunity here to leverage lessons learned from the COVID-19 pandemic to ensure that
looks like we may have frozen with Julian. Vagaries of technology. So I may turn to Karen for another question while we get Julian back. Karen, the question I have for you has to do with our healthcare workforce and how changes in our workforce can help us be more prepared for an emergency like the COVID-19 pandemic and others that we may anticipate in future years.
Absolutely. So the first thing is to think about the healthcare workforce in a more comprehensive way. If we widen our lens, we will consider both those persons that are clinicians and those other personnel such as community health workers, peer supports, and others who are so important in helping people navigate the health system in a way that is easily accessible, more readily understood. One of two bonuses that come from taking that approach is that community health workers and other non-clinical personnel, when they're part of the system and recruited from the communities they serve, there is more likely to be trust and easy engagement with those communities because they reflect who lives there and that diversity, as well as we will be helping to create jobs and economic security. And if we take our intentions and have the money follow our intentions, then from the task fund's perspective, we should be funding those efforts. So having something like a national program that focuses on the continued education, recruitment, and training of non-clinical personnel would be important. when we think about the clinical personnel, those people with advanced degrees.
Thanks very much, Karen. Let me
Yep.
turn now to Mark with another question.
Mhm.
And this one has to do with data collection and sharing. We've discovered as a result of the pandemic that the data capabilities of our federal government are not everything they could be. And especially we're lacking information on disparities in healthcare related to the COVID pandemic. And as we watch the rollout of the vaccine, the disparities in the uptake of the vaccine. So I'm wondering if you can help us think, Mark, about the opportunities for improved data collection that the federal government may be able to take advantage of.
Yeah, David, there certainly are. And let me also just begin by thanking you and the Commonwealth Fund for leading this effort. It turns out to be very timely because all these issues just are interrelated. One thing that I hope the COVID pandemic has made clear is that if we want to be better prepared for the next one, we need to do the same kinds of things that Karen was just describing, having a community health workforce, not only for protecting the public health, but also for being part of a better delivery system that moves more care upstream and enables people to get more help in the root causes of their health problems. So I hope we'll come back to that. But data is absolutely critical to that too. And as you know from your time in government, Office of the National Coordinator for Health Information Technology, we've had calls for a while for better public health, healthcare data integration. You know, I hope with the strong recommendations on this topic from the report that we're going to make more progress on that. And then related, David, as you said, to address some equity and access problems that emerge. We know they're there. We've seen huge gaps emerge in the pandemic. We just don't have the data systems interoperating to do something about it. So right now we're collecting a lot of data on vaccinations within public health registries. They're not being shared very effectively with the health plans, with the healthcare providers that are trusted by people who could potentially who are potentially subject to these disparities. And the report makes some very strong recommendations about filling in those gaps before the next pandemic. Requirements or recommendations related to starting to collect key information on quality and performance measures by race and ethnicity. I think the good news is that given all the attention to equity issues over the past year, we've seen more action by health plans, including Karen's and others, to try to get at linking that data. But we really need more of a concerted national effort. And there are a whole set of recommendations in the task force report about how to do that, both to help with responding to disparities that are emerging in national emergencies like this one, and more generally helping us tracking and therefore being able to do something more actionable about the disparities that exist in our underlying health system and public health.
Karen, do you have any reaction to that comment from the perspective of a health plan or and a Medicaid active health plan?
Sure. So my comment is it's easier than people are making it. When we've just gone and made sure that with every introductory call, we're getting race, ethnicity, and language data. We're tracking to ensure that there's improvement in our collection. And it was fairly easy, as with any other demographic indicator, to use that to identify the rate at which people were getting tested and coming back positive, connecting with a local, the local health information exchange systems in each market. All of those things were deployed very quickly. Thankfully, we had a number of those things we were doing before. And so it's a matter of intention to get started on it. And I wholeheartedly agree that we can accelerate that and be even better prepared the next time.
And I can't resist saying, as someone who's had a federal role in developing data resources, that our public health system is short on many things. But one of the most important things they're short on is healthcare IT infrastructure. It needs a total overhaul, and the rescue package that is might be considered by the Congress is an opportunity to invest in the information technology infrastructure that is essential to responding to this pandemic and the next pandemic. And that is one of the recommendations of the task force. And I would also point out that it's essential that that information system encompass reports from private actors, including suppliers of vital supplies that are necessary, for example, to make vaccination work in our healthcare system. We're now seeing big deficits and blockages in the supply chain that are new and unrecorded and that we need to capture in the future. So I don't know if we have Julian back, but I'm not sure we do. I'm going to move on to our next topic, which is payment. And we know that the payment system in our healthcare system has not worked extremely well during the pandemic. We've had major losses of revenue for many of our healthcare providers who survive on fee-for-service at a time when many individuals and who are seen in the healthcare system have been afraid to come and be seen. And that has resulted in dramatic reductions in income for many. So the question is, should we be transitioning to a different form of payment, one that emphasizes value, not volume, and that may be more resilient and more effective? So Mark, do you have any thoughts as a former head of CMS and an acute observer of our healthcare system generally about the role of value-based payment, what we've learned about it from the pandemic, and what its role should be going forward?
Yeah, David, as you might guess, I do have some thoughts on on this topic, and very fortunate that the report highlights many of them. And you talked at the beginning about how we started this process with the fund before the pandemic, but boy, if there was ever a wake-up call for needing to move to a different mechanism of financing our healthcare to get what we want, care that's upstream, care that can do the kinds of things that Karen was describing, reaching out proactively to people who are at risk, rather than trying to just keep your doors open because utilization is down and having to lay off staff. I think COVID was just a huge wake-up call. And as you said, we've got now lots of examples of how this can be done really well. Many organizations around the country are doing like what Karen described. This was talking with a healthcare group today that's moved into one of these advanced alternative payment models, way away from fee-for-service, where they've pre-positioned at-home COVID tests for all of their higher risk beneficiaries. If any of them have symptoms, they just do a telehealth call right away to get an evaluation for whether this is something that's serious enough to think could be COVID, and they've got a test there. And if it's positive, there actually are some things, as news today about monoclonal antibodies highlighted, there actually are some treatments for people who haven't been vaccinated yet, who are in high risk groups, and they get put into a pathway to get access to the monoclonal antibodies. And you heard from Karen about some of the steps that they've taken for their at-risk patients. We're seeing some of the same programs being implemented for addressing vaccination. So that's the kind of healthcare that we want. Taking that beyond the pandemic context, we need to move more care upstream with community health workers, with assistance from apps and digital technologies to help identify people who have risk factors and meet them where they are, and figuring out what's the best way to address them, kind of moving beyond kind of traditional medical services to address social needs. All of that is really hard to do without moving away from traditional fee-for-service. And so that's why the report makes some very strong recommendations to both for the pandemic and beyond to accelerate the adoption of alternative payment models. And we do now have a decade of evidence on models that work, such as accountable care organization models, which CMS is expanding in various forms. The private sector, states are working on as well. So the report encourages accelerating that, moving maybe to some mandatory models for these payment reforms, both for getting better primary care and specialized care, again, building on the evidence. The report also includes, recognizes that this doesn't happen overnight. Takes some new kinds of investments, some significant care redesigns. And so the report suggests a number of ways in which the federal government can help with some glide paths in supporting providers through this transition. And David, you had a wish list item for further congressional action on the pandemic. Mine would be to add to that, if there is more relief going out to providers or going out to trying to strengthen our public health system and align it better with our healthcare system, it would be great if that relief was linked to further movement in this direction. We've seen a lot of health plans like Blue Cross of North Carolina do their relief for providers in the form of helping them move into alternative payment models. The state of Washington is in the process of doing this for redesigning primary care to make it more robust, both for the pandemic and beyond, across multiple payers in the same direction. So again, these are recommendations that are very actionable.
And I'm noticing that we're getting some requests from our audience, and I just want to assure you that we will have time at the end for questions. So don't get discouraged from continuing to suggest your ideas and your comments in the chat. Karen, do you have any reaction to Mark's comments on the task force's recommendation with respect to value-based payment? You have a unique role in that you are heavily involved in Medicaid managed care, and therefore that would be your sense of how the federal government can make it easier for you to do value-based payment would be very
Sure.
valuable.
I agree with the recommendations. The federal government can do more to structure the supports that providers need. What the pandemic showed us was that there was a lot more resilience and agility that providers had as they began to reshape their practices, right? And so having the supports, especially for some of the smaller practices, and if you think about some practices that may be more rural, et cetera, they may not have the other practice to get the education and support from. And so investing in providing the necessary supports, which has happened before, what we would need to do is to accelerate, and especially coming out of the pandemic when practices have made significant changes to how they function, it's a great opportunity for us to leverage that agility into giving them the supports to move along the value-based and alternative payment method roads. Yep.
So I think one of the suggestions from the task force is that when we are asking providers to transition to value-based payment, that some may need some upfront technical support
Yes.
to make that transition. And that's more likely to be true of small practices with lesser administrative infrastructure. And I imagine that a lot of the Medicaid providers that you deal with fall into that category.
Absolutely. And as a Medicaid plan, and any insurer really, but particularly Medicaid plans, we're asking providers to do a lot to address the social needs, or at least make the linkage and referral. And so to the extent that we are reducing administrative burden as well, that goes a long way for them to be freed up to do the types of things that are not necessarily always in their basket of things, such as look at data about their panel and make decisions around how to do more population health management.
And David, if I could just add on this point, we actually have some evidence base for this. Medicare implemented a model called the ACO investment model, or AIM, that was, to Karen's point, specifically geared to small practices, rural practices, those that don't have a whole lot of capital to invest in, setting up these new models, provided also some technical assistance. And as the previous administration highlighted, this is one of a limited number of payment reform models that very clearly showed some improvements in quality of care and reductions in spending over time. So, great foundation to build on.
Terrific. Well, I was going to start to ask about the implications of pay for value for equity, but let me address with Karen directly some of the equity related recommendations from the task force. The pandemic has revealed just how unfair and unjust our healthcare system is, paralleling some of the injustices that are prevalent in society more generally. And these affect people of color disproportionately. Task force was cognizant of this issue and addressed it. And so a question for you, Karen, how can the federal government assist healthcare systems to actively confront and combat racism and to build back trust in the healthcare system among populations of color?
Certainly. So in order to build trust, I often say, and I probably heard it somewhere, so don't attribute it to me, that health happens at the speed at which trust exists or is built. And so if you are going to simply tell me what I should do and how I should do it, and I've never had a seat at the table in the design, the discussion about the policies and its implications, and all of those things that are important that happen before we do something, then I'm not sure I trust you. We also need to reckon with our history in this country of racism and not try to wash it away, but rather face it squarely. And when we do that, we then acknowledge that it's not that everyone's a bad person because they have bias. However, we know we have bias, and that's a human trait. Being aware enough and making changes in our practice and our behaviors and decisions is where the rubber hits the road. HHS should have like an office of engagement, which is one of our recommendations, so that we're saying it's required for you to engage and have those you serve at the table. It changes the conversation. We know over years of research, just looking at corporations, that when you have diverse boards and leadership, it makes a huge difference in how decisions are made and what the decisions look like. And so having this office of engagement would be huge to send a message. We can also do more and have more requirements around collecting data, using data, and sharing it, right? So being much more transparent with the information we gain over time about the disparities and the plans and the improvement. When all of that is right out there, we can have meaningful discussion, we can talk about change, and it will all inure to the trust of those we intend to serve.
So let me, and of course, another set of recommendations went to the pay for value idea and what we pay for and what we consider value. And perhaps both of you could comment on that perspective on equity, and particularly how the task force suggests that pay for value be adapted to promote equity.
Well, maybe I'll start saying Karen's comments already have touched on this. If you think about value and the way value is defined, it means different things to different people, but most of the efforts that have tried to look at it carefully do include equity as a high priority. On the other hand, and get back to those implicit bias issues, there are explicit bias issues we've just talked about. If you look back at the payment reform movement, it hasn't always paid close attention to that. And I think if you take the recommendations in the report, which as Karen just said, include putting a bigger emphasis on setting up programs in a way that reflect the input and participation of those who are served by them. So in the implementation of healthcare payment reforms, that inclusiveness, if the measures that are used for accountability, and David, you started off talking about getting to a healthcare system that's more accountable, that accountability should include accountability for equity. And if you take Karen's suggestion or Karen's recommendations about identifying some key measures where we are failing in equity, right now in the pandemic, certainly related to vaccination. We haven't, we're not collecting and reporting the data as well as we should, but anybody who's looking closely is seeing disparities emerge among the early vaccinated workforce and the like for exactly the kinds of reasons that Karen described. If we had more explicit measures that were built in, and if we had designed our value-based care reforms and the payment reforms to support them to reinforce taking those on directly, just imagine how much more progress we could make. So, whether it's vaccination in the COVID context or maternal mortality or cardiovascular disease outcomes or access to and quality of and outcomes for substance use disorder care. You can imagine a limited number of measures that could really help change the way that that value-based care takes on these issues more directly.
Karen, can you imagine a way in which Medicaid might pay for value, where value includes equity as a measure of performance?
Absolutely. So today I'll share an example. Our value-based programs focus on the 3 pay-for-performance measures that we have in DC, but this is replicated in other markets we serve as well. And we've included some process measures around social care, right? So are you referring to us those persons that are facing food insecurity, they need certain items such as diapers, all those things. Are you making referrals to us? So we have those other measures to capture, is this practice focused on the social care component more holistically? And so if we shared with that practice data, let's say it was an OBGYN practice, and we did the work to share our review of their panel and our analysis to say, based on race, ethnicity, language, and other factors, here is a report for you that says where you have clear disparities. We're doing that at an aggregate level over our membership. So if we did that for practices, and just in the same way that we send them regular report cards about how they're doing on their on their value-based measures, we included that. Now we've given them information that they necessarily didn't have before, and we provide the tailored technical assistance, which we do today on the other measures. Then they're now getting the support they need, the coaching, and the ability to see how they're doing with creating change. And so I see it as possible with support to help them move along. And again, if we reduce some of the administrative burden, they do have more time to look at data, have the discussions with us, and move along that continuum of improvement in terms of their outcomes.
Just to follow up on a comment that you made a little bit ago, to be a little more specific, you talked about an office engagement at HHS, and with the idea that that would promote greater participation on the part of communities, especially communities of color, in the work of the healthcare system, and make it more, increase their trust in that system and make it more responsive to their needs. The task force did address the issue of governance in our healthcare systems. For example, as a condition for accreditation, that those governance structures should be more representative of the communities they serve. Would you like to comment a little more on that?
Sure. So, when you look at corporate diversity, equity, and inclusion work, representation matters. It matters in a number of ways. And we know that corporations that have diverse boards, CEO suite or C-suite personnel, and senior leadership perform better. That corollary, to me, would also apply to healthcare. Having the diversity in leadership, building the pipeline with people from communities we serve so that they're moving along and being part of the decision-making process is incredibly important, because you can sometimes have discussions and say, well, I think and we think. However, if you've never, not that you have to have had the same experience, but if you've never had that conversation, so that you are getting the appropriate inputs. And in healthcare, it's just interesting to me that sometimes we skip over that. We have to get the input from our consumer, and we have to understand the circumstances, the laws, the processes, the structures with which they are dealing that become barriers, and address them. And so having all of that diverse representation will take us a long way to better decision making, better outcomes, and increasing trust, which not a lot of health is going to happen, especially in communities of color, without that increased trust.
So I'm told we have Julian back on the phone. Julian, are you there?
I am there.
So
I'm here.
we can backtrack to where we started with you, talking about the culture of preparedness and how to make it possible in our healthcare system, what the task force has to say about that. You've had a little more time to collect your thoughts, though I imagine you've been frantically trying to reconnect with us. So take a deep breath, and maybe you could comment again on the culture of preparedness and how our recommendations can augment that culture.
Thanks, David. I think there really is an opportunity to take a step back, and the temptation is to wait until after a crisis or a pandemic is over to begin to reflect on lessons learned and to document those lessons learned. But the risk of doing that is that there are just some things that you learn sort of in the moment. And so, with the kind of elevation of COVID pandemic response within the National Security Council and some of the other structures that we've seen put into place, I think there's a real opportunity to ensure that the updates to the National Pandemic Preparedness Plan are happening as we speak and continue sort of at pace throughout the balance of the pandemic, so that we're collecting those lessons learned. There really are opportunities to think about how we strengthen the coordination between local public health authorities, state public health authorities, and the federal government, ensuring that particularly on the state and local side, that those organizations, which historically have been under-resourced, truly have the technology infrastructure that's needed, have the mechanisms to scale up community-based resources like community health workers when needed, have the ability to coordinate with health systems to ensure that they have access to the supplies that they need and to do capacity, both sort of cataloging, but also management in a dynamic fashion. And that there's a kind of relentless focus on the importance of primary care as a component of a broader public health strategy. So one of the challenges that we're certainly seeing right now, for example, is that primary care providers in certain cases don't have a clear understanding of how to get access to testing or how to get access to the vaccine. And I think having the processes in place with those primary care providers who ultimately will need to play a critical role is important. We've seen in sort of an opportunistic fashion pharmacies and partnerships with organizations like CVS and Walgreens, but really those organizations are so entrenched in the fabric of our sort of national provider infrastructure, as are independent pharmacies, et cetera, that we actually should think in a structured way and include those organizations in our public health preparedness going forward as a part of our kind of extended delivery system. And there are other components of the private sector, certainly, that could play a role there. There have also been a couple of places where there are innovations that I think many of us who live sort of in the healthcare innovation world would like to have seen move more quickly prior to the pandemic that have been accelerated, and a couple of examples that have gotten a lot of attention would include telehealth and hospital at home. And I'll just flag those as examples. Those are both areas where work has been done really over decades, building up to a moment where there's widespread adoption. But I think now that we've seen the role that telehealth can play as an extension of the care delivery system, and we've seen a number of major health systems across the country, from Mount Sinai in New York to Partners Health System in Boston, and dozens of others now with broadened authority that's been made available under the public health emergency from CMS. We've seen hospitals step up to be able to think about delivering services in the home. And I think that some of those innovations are ones that I hope we can built into the system, so the next time we have a crisis, we're not having to try and sort of accelerate our policy making and can match policy making to the broader needs in the market.
So you mentioned primary care, and I'm a primary care physician. Julian, you trained in medicine. Mark, I expect you trained in medicine. I don't know if you were trained in primary care as I did, but one of the enduring frustrations and dilemmas of our healthcare system has been the shortage of primary care clinicians, whether they're physicians or nurse practitioners or physician assistants. And that's especially true in, I think, communities of color. So one of the questions is, what, from the task force, what are some of the things that we could do to build primary care? And I want to say that as living here in Cambridge, Massachusetts, a few miles from Massachusetts General Hospital, where I get my primary care, I still find that my primary care clinicians have no idea how to participate in the vaccination of their panel. So this is really an issue that touches every American, even those of us who are privileged to be close to major institutions. So any comments from our panelists on that issue?
So I think that there are really significant opportunities, and there's a Venn diagram with some of the conversations we've had around payment reform. You know, I trained in primary care as well, and one of the challenges I think that we have is, you know, we have an opportunity to broaden the pipeline, particularly as we think about expanding representation from communities of color amongst the ranks of physicians. You know, there's sort of that as a macro issue across all sort of subsectors or subspecialties within medicine. But I think primary care is particularly challenging because of the way that we've structured reimbursement. You know, I've been fortunate to wear a few different hats in my career. Beyond being a physician, I've been both on the federal side and then in the private sector on the health plan side. And my mantra has always been, we can significantly increase what we reimburse or how we compensate primary care providers if they are doing all the right things to help improve quality for the patients that they serve and are helping to manage the health of populations. If we think about the delta between reimbursement for primary care versus specialty care, it really is a deterrent for students who have significant student loan debt, who are trying to make trade-off decisions, who in many cases may be the first person in their family to go to college, you know, not to mention to pursue a graduate degree. And so I think, you know, some of the things we need to do to make primary care more attractive more broadly will also help to actually diversify who ends up selecting primary care as their chosen profession, because we're closing that gap between primary care and specialty care. And it enables folks, I think, to make different kinds of trade-off decisions as they think about how to close what is an economic and a wealth gap in the country as well between communities of color and others. And so I think those are some of the things we have to have on our radar. But I also think it's expanding beyond just physicians in the conversation and thinking about nurse practitioners, thinking about physician assistants and extenders and others who play important roles in primary care.
Just to build on that, the report included a number of recommendations related directly, you know, enhancing and diversifying the primary care workforce. But just to focus on the point about payment reforms that can help, just about all of the successful payment reform models I've seen end up channeling, you know, relatively more resources into primary care, but primary care broadly defined, not primary care just with a, you know, a single doctor. And I trained in internal medicine too, but a, you know, single doctor in a practice, but rather a team approach, one that can interact with community health workers, one that can connect to, as Karen was describing earlier, programs to address social needs that patients have, one that embraces new data, you know, longitudinal data tracking of patients and digital virtual supports around telehealth. So that's a different kind of model for care. It's not just increasing the payment for primary care providers, but changing the form, making it more about, as we recommend in the report, partial or even fully direct contracted models, maybe with some accountability for overall costs. And as Karen was just describing, some accountability related to really improving the care experience of the population they serve, not just the people who come in the door for the office visits. So there are a lot of recommendations in the report about that. And like I said, if you look at the evidence, the models out there that have built around this broader notion of primary care services that get at the whole health needs of a person or a population being served, they end up paying significantly more. Some of the primary care-led ACOs have physician practices, again, with these broader teams that have substantially higher incomes. We're talking about not 5% of healthcare spending, but 7-8% more going into the set of services. So the recommendations and report, David, provide a map to help get there.
Karen, as a nurse, I'm assuming that all this talk about doctors may lead you to think there's another perspective as well on primary care and supply of primary care. Do you have
Yes.
anything to add?
Yep, we need to be investing to get nurse practitioners and PAs, as well. One of the things I found, this is just a data point, so it may not represent what everyone else has seen. Our nurse practitioners have been incredibly flexible. So I've had for the last 3 years a nurse practitioner or two that do several things in a very flexible fashion based on us referring. So for any of our members with 3 or more hospitalizations, they go to the hospital and have a visit to understand from the consumer's perspective what happened. They do coordination across the care team for medication reconciliation. They will go with our member to their next appointment post-hospitalization to be part of the conversation and help enable the member to talk about, and they're there then to hear firsthand and reinforce learning. So we've had amazing experience with nurse practitioners being very flexible about how they practice. During the pandemic, our nurse practitioner has been doing home visits where the consumer is like, yes, come and visit. So we should think more broadly that it's not just about the physicians. Nurse practitioners and physician assistants are amazing adjuncts, and their cost in terms of loans and such don't tend to be quite as high as what physicians have experienced. And so they can, get right in there and start working and doing things without feeling like everything has to be at the reimbursement level of a complex office visit.
Well, the task force report, as several of you have said, was very strong on a couple of things related to primary care. First, that payment should be designed by Medicare, Medicaid, and hopefully with private sector support to assure compensation at a level that supports an adequate supply of primary care clinicians. And that should be a goal of compensation, not something that is left to chance. Also, that compensation of primary care practitioners should be a combination of fee-for-service and prospective payment that gives them more job security because they're not dependent solely on the volume of services they provide. And I also expect that some of our recommendations with respect to telehealth would be support the development of a stronger primary care infrastructure in rural areas and areas where supply is scarce. And that would also be an important thing for the federal government to pay attention to in the current environment. We did have one question that gets a little bit past where we focused on in the task force, but is relevant, and that has to do with multi-payer alignment with respect to payment. So most of our recommendations were focused on the federal government and Medicare, Medicaid as part of that. There have been a number of experiments with aligning private and public payers, and we certainly would have thought that was a positive thing to think about. Do the panelists have any thoughts about the role of the new administration in that area?
This is Mark. I mean, I saw that question from Tricia, and she should know firsthand from some of her experiences about the challenges of doing it, but also that payer approaches are possible. We've seen some progress even in the pandemic in a number of states. Washington is a multi-payer initiative now, David, to this last discussion about primary care that's really focused on this kind of more expansive version of primary care. Oregon, accountable health communities, other states as well. I think it takes leadership both from states and from the federal government to do effectively. And if they're not both aligned at the table, then it's hard to make it happen. And that is an opportunity that the federal government has. David, you may remember that there have been a number of, or all of you, that there have been a number of multi-payer payment reform efforts in CMMI and in the payment reforms, such as the comprehensive primary care and CPC Plus initiatives. Now, those didn't quite get there in terms of achieving both net savings and improvements in access. And I think what we've talked about today, this broader notion of primary care as a team that involves nurse practitioners and others, and that really tries to extend out to meet patients' whole health needs, building off models like the AIM model and the physician-led or the group practice-led accountable care organization programs could do it. But I think it is going to take leadership from the administration to work with states on that, maybe by providing a couple of models. And also, I would say administration leadership on engaging with the public about it. What is it that, people don't care about being an ACO or a payment reform. What is it about these reforms that they can really care about? And, the CPC Plus model, not to get too technical for a minute, got into a lot of details about, how exactly a practice should be set up. And I think lost a little sight of the big picture, which is this model going to improve equity in important dimensions of care? Is it going to improve patient access and experience as experienced by the patient? So with a limited number, maybe meaningful performance measures, I'd really like to see a multi-payer initiative coming out of the new administration.
Julia,
Yeah, and
go ahead.
Yeah, and I think there are also opportunities to collaborate with private payers. We've seen an incredible amount of innovation from private payers, both ones that are administering government programs like Medicare Advantage or Medicaid managed care, or even ones who are working with the public market. But I think that the commercial payers as well are doing a number of innovative kind of activities, both in kind of the total cost of care, accountable care type models, but also in episode models. And so I think there's certainly opportunity to really think about true multi-payer collaboration across Medicare, Medicaid, and commercial, and for CMS to continue to build on the work that it's done with some of the other models that have been mentioned as they think about this kind of next generation of models, how to engage with the private payers, because in certain cases they have the ability to be innovation laboratories, or may actually have at this point, some provider relationships that have a pretty extensive track record of value-based payment that they can build off and learn from.
Great points. So before we leave, we have a question that goes outside the focus of the task force report, but since we have such excellent expertise with us, there was a question about changes the new administration is expected to make or has announced to strengthen the Affordable Care Act. And Mark and Julian and Karen, do you guys have any thoughts about what you've heard or what you expect to see?
Well, David, there have been a few initial steps already the administration's taken or made clear that they are taking in suspending and rescinding a lot of the regulatory actions of the previous administration, especially the late ones. Some of those did have to do with the ACA. I think something to look for right away is reopening of a new open enrollment period for people who've lost coverage in the pandemic, giving them another chance to participate in the Affordable Care Act exchanges. And I think you're going to see some more rules building on that. There was a really thoughtful, for those of you who are interested in going deeper on the topic, Joel Ario and colleagues had a blog in Health Affairs recently about how the administration could match up some ACA strengthening steps with steps to help support Medicaid programs as well. And just one more comment, there are a few states that are really thinking about leveraging value-based care, like the recommendations in this report, into the ACA. California and covered California is a good example of that, and that the administration may want to build on too.
Yeah, I keep thinking that at some point we're going to be emerging from the pandemic. And when we do, so many of the people who were retained on the Medicaid rolls due to the public health emergency will be rolling off. And so whatever we do, we need to keep that in mind and ensure that we are planning now, because some of those people, I imagine, would be able to be on the exchange, right? So beginning to think all of that through so we don't end up with a time where we have disenrolled people from Medicaid and they're not aligned or knowledgeable about what happens next, and we end up with really some level of catastrophe. So we need to give a lot of thought to how the program is strengthened, how people are made aware, and how there's well-coordinated planning.
Yeah, I think that there are a number of opportunities to build on the Affordable Care Act that that we've either heard during the campaign or heard since. There are certainly opportunities to strengthen the exchanges. That's clearly a priority. There are opportunities to think about not only leveraging the Medicaid program to think about how we might address coverage more broadly post-pandemic, but are there ways to think about making Medicaid expansion more attractive for states that haven't expanded to date? I think we also have to remember that while ACA is often most associated with the coverage expansion, it did do a lot to catalyze a greater focus on payment and delivery system innovation, most notably with the creation of the Innovation Center. But, a lot of the things that we're talking about from a payment reform perspective will likely build on the authorities under the Innovation Center that were a part of the ACA, whether that's expanding hospital at home and others. And then certainly there were the components of the ACA that were public health focused and that could be built upon as well, from kind of the work related to the Prevention and Public Health Trust Fund, which was a part of the ACA, some of the work related to expanding the National Health Services Corps, which was supported through the ACA. So I think if we're kind of taking the act broadly speaking and not just, as we often do, kind of focusing narrowly on the coverage expansion, I think there are a number of ways that can be a foundation for some of the other things that might be addressed in kind of a post-COVID world.
Well, I think we've gotten to the end of our time. I want to thank our panelists for a terrific conversation and for their participation in the task force. Also want to thank our audience for their terrific questions. I'm sorry we didn't get to all of them, but time has run out on us. If you missed any portion of today's discussion, it will be, we'll share the recording and all the resources that have been mentioned via email. So I want to thank again our speakers and our audience and all my colleagues at the Commonwealth Fund and elsewhere who've made this webinar possible. I hope you all have a great day.